glad everyone's here. Let me start by thanking the Center for AIDS Research, the CFAR, for co-sponsoring this and really allowing us to bring Mark Barnes to Hopkins. The CFAR is very active at Johns Hopkins, and we're fortunate that there's a Bioethics and Human Rights Working Group within the CFAR that has allowed us to bring Mark. So I first knew of Mark Barnes back when he was at the New York City Health Department running the Ryan White program for New York City, which was a tremendous new kind of responsibility that people working in HIV had in the 80s, 90s?
91 was the first year.
91. And he was doing incredible public service related to HIV. And then his career has transitioned such that he is now at Ropes & Gray, one of the big, important, prestigious law firms in Boston. He also has a lot of affiliations at Harvard, and I'm going to read this to make sure that I don't lose some of the important details. Mark has served as the Associate Provost and Senior Research Officer for Harvard University, and I know in that capacity has overseen really a lot of the legal responsibility for all of the international programs of a big university, working in a lot of different places, including doing a lot of HIV research. He currently serves as the faculty co-chair of the Multi-Regional Clinical Trials Center at Harvard, which thinks about doing clinical trials in emerging economies. He served as the executive vice president at St. Jude's Hospital, and he also continues to teach at Harvard in the law school, working out some kind of arrangement between Ropes & Gray and Harvard that I'm sure a lot of people would love to know more about. So we're really glad that you're here, Mark. I also do want to highlight that after the seminar, there may not be enough time for questions with this larger group, but we're hosting a sort of meet and greet, much more informal conversation with Mark at our building, our Bioethics building, Deering Hall, immediately afterwards. So really glad you're here, and welcome.
Now it's on. Okay, can you hear me all right? Yeah, great, excellent. Okay, so good afternoon. Good afternoon, everybody. It's nice to be here, and thanks to all of you for inviting me. It's a pleasure to be here. What I have done a lot, I've done a lot of work in this area of HIV services and HIV prevention services, care and treatment services, and research, and especially in Africa. Not only in Africa, but I have become sort of I guess more or less an Africa expert over the years because I've done so many things in so many different countries there. And there's some times that I've written about some of these dilemmas that we're going to talk about today. About a year ago, or maybe 2 years ago, Bernie Lowe and Nancy Padian and I had an article in JAMA, a short article, about some of the issues in HIV vaccine testing in Africa and other developing economies. But mostly what I know is not reflected in writing because I haven't written about it. It's just stuff that I've done and decisions that I had to make myself or with colleagues in these programs as we operated the programs. And so this is very much today a sort of a lesson in applied ethics. It's really sort of what happened, what the problems were, and how we decided to solve them, on the fly because we had to solve them. We didn't have time to write about them or in some cases even really think about them that much. We tried to do the best we could under the circumstances, but it was very much a kind of it was a work in progress. It was really, as I said, it was a set of applied ethics. So what I'm going to do today is I'm going to go through a little background on some of the complications in international health services and health research projects to sort of set the stage. Then I'm going to go into a series of problems. Really, they're phrased on here as questions, but I will tell you that behind every single question on this slide deck, there actually is a real-life controversy that I have been involved in and that I've had to solve one way or another. In some of the cases, when I tell you about these things, I will change the names to protect people because some of this stuff is actually, quite controversial, and I rarely talk about some of this stuff actually because it's controversial, the decisions that we made in some cases. And then I'm going to finish up by talking, if we have time, I'm going to talk about a study that is being done by the HIV Prevention Trials Network called 071, which is this massive cluster randomized trial in 21 communities in Zambia and South Africa, for which I serve, and it's trying to test different levels of HIV intervention in the HIV prevention intervention and treatment intervention in these communities, to try to understand whether a very aggressive method of treating people with HIV early and well, and I mean early, as soon as they're diagnosed with HIV, regardless of immunocompetence, as measured by CD4, to see whether doing that will actually has the prospect of choking off the epidemic in a new way. So, and there are a number of ethical issues that have emerged in that. I'm the ethics working group of the HPTN advisor on the study team for 071. Jeremy Sugarman, who's sitting right here, is the chair of the ethics working group. And so I've had to deal with, in a kind of more organized way than some of the earlier things that we're going to talk about in terms of the problems that have emerged in the study design and the study conduct, and especially the issue of informed consent in a huge cluster randomized trial with over 1 million participants. So with that, let me go into this first. You know, one of the problems here, I mean, why is this so complicated in regard to health services and health research? It is because we are seeing the growth and the transformation of these regions, which used to be called the developing world, but increasingly they're called the emerging economies, because there are aspects of these countries, whether it's India or whether it's South Africa or even whether it's Nigeria, in which there are pockets of the country that have medical services and health services that are equivalent to anything that one can get in the US or Western Europe. But there are other parts of the economies that obviously are, that we know are quite poor and are severely resource constrained. We have increasingly a number of researchers who are from these countries or who live or are resident in these countries who actually are world-class researchers. So they're doing the same kind of work that we're doing. So we have a kind of integration of research teams across these different countries and across these institutions. We also have the geopolitical aspects, which I think can't be discounted. I mean, the fact is that although, you know, I think President Bush should be thanked for what he did when Clinton didn't do it in terms of the true HIV relief in Africa and in Vietnam and in Haiti. Nevertheless, there are geopolitical aspects to what was being done and to why some countries like Nigeria were targeted at the beginning and why other countries like Zimbabwe were not. There are some major geopolitical implications of this and reasons behind the interventions. So, and then there is just the fact that much of this stuff that we're going to talk about today and much of the stuff that is done here at Hopkins, I know, is funded by the US government or it's funded by the Gates Foundation, but if it's funded by the US government or the EU, there are a massive number of grant terms and conditions that attach to all of this money that is used for health services delivery projects, for what we are beginning to call implementation research, and for clinical trials that are done anywhere, but especially the difficulty in trying to enforce and comply with all of these incredibly detailed terms and conditions of USG grant funding when one does it in places like Nigeria or Zimbabwe or Tanzania, in which the infrastructure of the institutions that are the partner institutions is simply not what it is at a place like Hopkins or Harvard, and how one does that and the ethical choices that means that one has to make. So in our global research at a public health school or a medical school like Hopkins, there are benefits and there are challenges in all of this, and I just put some of them up here. It's a slide that I sometimes use in trying to talk through some of the challenges. But one is, there are lots of benefits benefits that inure to the school and the faculty as well as to the students and the postdocs. But there also are a number of huge challenges: managerial costs, safeguarding reputation in these projects that are 8,000 or 12,000 miles away, effective communication with collaborators and with research subjects, and effective management of ethics, because there are, at the end of the day, some poignant ethics choices that emerge from all of this. Now, the other thing that before I get into the meat of this that I want to go through, sorry for the animation on the slide, which I would not have chosen. I use this slide sometimes to illustrate the range of interventions, the range of complexity of interventions that we have in a place like Hopkins or Harvard or other places in terms of engagement with facilities and people and collaborators and research subjects and patients outside of the immediate environs of either Boston or Baltimore. I mean, up here, the sort of least invasive intervention is traditional public health research. Doing an epi study or doing a policy analysis or writing a paper about it. And then at the bottom is stuff that actually does go on at Hopkins, I believe, which is actual delivering care, taking full responsibility for day-to-day care of people abroad, when one doesn't, before initiating the project, have the infrastructure to do it. And then there's a range of stuff in between. There's consulting, like management consulting. There's funding services that are delivered by others. For example, the whole PEPFAR model is that the U.S. government gives massive amounts of money to U.S.-based institutions that are generally not-for-profits, so that they in turn can decide who should be, which institutions at the local level in 15 target countries should receive the money in order to deliver care. So the PEPFAR recipients in the U.S., whether it's FHI or Elizabeth Glaser Pediatric AIDS or Harvard or anyplace else, or Hopkins, we get money and we fund other people to give services, but we are responsible for the quality of the services that are delivered. So that's a different model. We're not actually delivering the services. Somebody else is putting their hands on patients. Patients are not supposed to think of us as being their caregivers, but we are responsible for what happens to those patients in the field because it's our money, and we took the grant. So and then there are also, especially in terms of clinical medicine, there are a number of distance-based services in which there are second opinion services, teleradiology that's going on all over the place, in which actually the flow of expertise is the other way. There are places in India that have very skilled radiologists who can read scans for a fraction of the cost of what it costs under the Medicare and Medicaid billing fees here in the U.S., and they do that for people in Europe. They do it for people in the U.S. sometimes, although there's some questions about the practice of medicine and what the licensure issues and that sort of thing. But there's a range of interventions here that we're talking about. And as you go from up here to down here, you're increasing in complexity, you're increasing in risk, you're increasing in the amount of money that's being spent, and you certainly are increasing, in my experience, in terms of the ethical challenges as you go from the least intrusive to the most invasive. We also know that clinical research increasingly has moved away from the U.S. And if one actually looks at the number of applications to the FDA, the clinical trials that are used to support FDA applications, you'll see that over the years, inexorably, year by year, the number of trials that are done in the U.S. declines, the number of trials done outside the U.S. increases, and the number of trials done outside the OECD countries increases. And so there are, for example, in regard to the biotech agents that are being proposed for licensure at the FDA, last year, 87% of all research subjects in trials supporting those applications were outside the U.S. So the way that this stuff has been offshored by pharma, including, and not just pharma, but also in public health research, is sort of astounding. And why is it? I mean, there are lower site costs, there are fewer competitive trials, treatment-naive subjects are nice for investigators to have if they can find them. And then there are disease-specific study needs. One can't really study malaria, yellow fever, and tuberculosis very well in the U.S., or at least in most parts of the U.S. And then there are countries that are actively trying to attract both for-profit companies to do, or sponsors to do clinical research, as well as to attract not-for-profit academic sponsors of clinical research. And but if one looks at each of these kind of advantages, with every advantage of citing a trial or a service abroad, there is a corresponding ethical challenge. So, for example, lower site costs, yes, but that means that one has to question whether the money that's being given to subjects and to collaborators is actually kind of an undue incentive to participate in the research. And there are informed consent challenges. Fewer competitive trials and treatment-naive patients. There's a reason for that, which is that there's not good background standard of care. So what does one do with the control group in those kinds of studies when the background standard of care is poor and is not equal to what it would be in Baltimore or in Boston? And in addition to that, what does one do about continuity of care after the study or the research project ends? When funding ends, people have been receiving some standard of care, but the background standard of care that they're left with after the study ends goes away, departs with the researchers and the money from Hopkins. And then in some cases, as I said, national governments can be very aggressive about encouraging clinical trials to be cited, or health services projects or demonstration projects to be cited in their countries. But what one part of the government gives, another part of the same government can just as easily take away. And so we've seen recently, for example, in India, India has become a massive site for clinical trials, both public health trials funded by Gates and others, and the NIH, and also pharma company trials, and not just Western Europe and US-based pharma companies, but India-based pharma companies as well. So there are a number of CROs, of private for-profit CROs that have emerged in India, and that has become a huge business. However, there's recently been a regulatory change in India, which regarding the compensation for subjects who are injured as part of a clinical trial, that basically has resulted in not a single new clinical trial being initiated in India since January of this year, in a country of 1.2 billion people. So as soon as regulators can support trials, there could be regulatory changes that choke them off as well in a way that is not as predictable as the way that our own FDA behaves, at least in most cases. So there are these risks that I won't go into, but there are liability issues, there are grant terms and conditions. We get committed without realizing all of the full implications to what it is that we are doing there and what happens when we leave. The promises that people there think we've made, and the promises that we're actually able to fulfill based on the limited grant funding that we have. And we have often, as I said, tenuous infrastructure among the collaborators and the collaborating institutions on whom we depend, or on which we depend in our studies. So here are some specific ethical problems that I have seen in my own career. By the way, I mean, one of the things that you didn't say is that I was the first executive director of the Harvard PEPFAR program. And so I was actually the first, third, fifth, and seventh executive director of the Harvard PEPFAR program, because no one else could survive. So we lost a lot of people along the way. The quickest turnaround was 2 weeks. I trained somebody, left, he quit 2 weeks later, and I had to take over as the fifth executive director. But so I started the Harvard PEPFAR program, which was one of the first 4 PEPFAR programs that was started, was funded by the Bush administration. It was us and Elizabeth Glaser, Catholic Relief, and Columbia. Thank you, Mailman School of Public Health at Columbia. And so we were one of the 4, and so we were at the beginning. Some of the reason that I experienced some of these things is because we were going into a program that really was the massive delivery of health services. And remember, in the PEPFAR program, not a single dollar of PEPFAR money can be spent for research. It can only be spent for direct services. And so it was Harvard University, it was Columbia, in the schools of public health, delivering care, actual long-term ARV treatment to hundreds of thousands of people. And so I'll get into that a little bit in just a minute. But so here's one of the problems that we had originally. We opened in Nigeria, Tanzania, and Botswana. Those were the 3 countries that were our target countries for Harvard. Tanzania and Nigeria were largely treatment naive entirely, except people who were wealthy enough to fly to Western Europe, buy the drugs, and bring them back. Right? This was in 2004, late 2004, early 2005. But there was massive demand, especially in Nigeria, for these services. Many people knew that they were positive, they'd been tested, but they had absolutely no treatment. And so one of the first questions that came up is, how do you ration care? Because as soon as we opened treatment slots at 5 different hospitals or 10 different hospitals, then what does one do with the fact that people are lined up at literally 3 o'clock in the morning waiting for the clinic to open at 8 o'clock because they want antiretrovirals? How does one rationalize among them? And so we had these early debates, very early debates. I mean, in the first few weeks, so before we even started operating the clinics, I said, how are we going to sort this out? I mean, who should come first? Should it be people with the lowest CD4 count? Should it be pregnant women? Should it be the breadwinners of their families, because we need to keep them alive in order to take care of their 5 kids or 4 kids or 3 kids or extended family with nieces and nephews and everybody else? Or should it just be first come, first served? And interestingly, the clinic staff in Nigeria, almost to a person, they had an entirely different way of looking at this. They thought that their friends and family members should come first. And it was not, and if you probed, so I was like, I couldn't believe it when I first heard this. I thought, how could this be? I mean, if a doctor at Hopkins said, my brother should come first with a kidney transplant, you would think that the guy or woman was off their rocker, right? So, but their reasoning was this. They said, we have been toiling in these unfunded clinics on our volunteer time now for 5 years in taking care of AIDS patients. We have done this out of the goodness of our hearts. We have endured, basically terrible conditions, and the conditions, believe me, were absolutely horrific in the Nigerian hospitals that we began to fund and assist. And so they thought, well, if this is the case, then why shouldn't I get something back out of this, and why shouldn't my family and my family's friends come first as part of the repayment for what I have done for so many people for so long with absolutely no pay and no recognition? So there was, I have to tell you that the resolution of this, we didn't reach a resolution of this. The only resolution of this that I could see was to get as many treatment slots open as quickly as possible so that this issue would dissipate as an issue. But frankly, this is sort of like one of these, like Guido Calabresi's tragic choices. You don't want to know how the choice is made, actually, because it is so. Because trying to come back and tell HRSA and CDC and HHS and the Department of State that any clinic of ours was prioritizing the friends and family of the caregivers, they would have. It would have been horrible, right? So I'm sorry this is taped because I wish I had never said that. It was recorded. But anyway. You can unrecord it. So this was a real life issue, and we had some very heated debates among our Nigerian collaborators, especially about what we should do. Then there was the issue which rapidly came up of what about the woman who is admitted as a patient, or the man, and all of a sudden they have a wife or a husband or a mother or a child, most poignantly, and the child has epilepsy, or has some other chronic condition that has absolutely nothing to do with HIV. In fact, the child doesn't even have HIV. But the mother is bringing the child to the clinic because this is the first real care that the mother has ever had in a sustained way. What do you do about ancillary care? This is there's a small literature out there about what one does about ancillary care in a study. But there's yet another iteration of it, which is not just ancillary care, but what about the individuals? Remember, PEPFAR money can only fund outpatient medical care. It can't fund nutrition. It can't fund inpatient care. There's a limit to what the funding stream defines the service, right? Whether it's the Gates Foundation or whether it's the EU or whether it's HHS and Department of State through PEPFAR, we can only do that which the money allows us to do, the grant terms and conditions allow us to do. So we would get people in these clinics in Nigeria whom we could treat with ARVs, but they didn't have food to eat. Literally, they didn't have food. And this is especially actually in Tanzania as well. It's a terrible situation. So you can give them ARVs, but you can't give them nutritional supplements. So what do you do in a situation like that? So I came up, after thinking about this for about 3 days. This was no organized ethical thought. I came up with the idea that, this was entirely back of the envelope. I just kind of backed into it. I thought, how much money should we give to the caregivers at each of our partner institutions that will give them enough money to do something meaningful with over a 1-year period of time? And I thought, well, $100,000 would be enough to give them like a fund from which they could actually make a difference for a limited number of patients. So I backed into the number of 3% because 3% was yielded in the larger clinics, 3% of their total annual budget from Harvard yielded about $100,000. So I wrote some rules and said there has to be a committee composed of caregivers and a couple of patient representatives with minutes held, minutes recorded, meeting once a month to go through applications made by caregivers on behalf of patients at that clinic. And you can do whatever you want with this $100,000. I don't want to know what you did with it, right? So this is and that was a way that I could kind of like offshore the spending. But I also forced the decision making down to as local a level as I could. So it was rationing care. It was rationing nutritional services, rationing rent in some cases. But what I was doing is relying on those people who knew best, which were the caregivers, and then a couple of patient representatives to kind of sort through the applications to make the decisions at the local level. So that became the 3% solution, and it was then followed by some of the other grantees in PEPFAR. But it was just something that I didn't know what else to do except leave the responsibility at the local level with enough resources that they could actually make a difference. Then there's a question that rapidly emerged in the Harvard program that we did viral load testing. Nobody else did viral load testing. But we did it largely because the PI, I was the executive director, we had a PI, and the PI was a laboratorian. And so she really wanted to capacitate laboratories in Nigeria, Tanzania, and Botswana to do viral load testing. Nobody else did viral load testing. So it was a very strange thing. In fact, the US government, which thought that was a wonderful thing to do in years 1 and 2, by years 3, 4, and 5, decided that that was a terrible thing to do because we were establishing a standard of care that exceeded the other PEPFAR grantees in these countries. So they wanted us actually to stop the viral load testing, and we went through a period of negotiation in which we refused to stop the viral load because we thought it was consistent with the US standard of care, and we thought we had money enough to do it in the budget. So we continued to do it. But after Harvard in order to get to have an end game for the PEPFAR program, which is not on the slides, but I will tell you this, Harvard could not keep doing this program forever because Harvard School of Public Health, I mean, aside from this project, it runs no clinics, it provides no medical services, it had never done anything like this amount of direct care in the history of Harvard. Even though Harvard Medical School, faculty only get paid for teaching and research. They don't get paid anything for delivering clinical care at Harvard. Harvard had no capacity to do this program, so although we started up an infrastructure so that we could implement the program, we had to work our way out of the program. And so the way we did that is that we established NGOs composed of, with boards of trustees of people who are from that country in each of the 3 countries. We capacitated them, we moved all the Harvard employees in country into those NGOs. We trained them to USG grant terms and conditions and EU grant terms and conditions standards. We capacitated them fully. We put them through a testing program using the HRSA primary care clinic methodology of testing both financial systems, administrative systems, and clinical systems. We did quality assurance like crazy throughout these clinical systems. And then we persuaded the US government that on a date certain, which turned out to be September 30th of last year, that the US government should take every dollar that went to Harvard and send it instead to these 3 NGOs in these 3 countries. And Harvard would be out of it. And it would be money going directly from the USG to NGOs that were fully staffed only by people from that country. And we did it. And we did it on schedule, and the money transferred September 30th. Now, the reason I'm telling you this is because after Harvard was able to defend the viral load testing, but after the NGOs took it over, the USG was able to put a lot more pressure financially on the NGOs than they could have on Harvard. And so my understanding is that the viral load testing has ended in Nigeria because of that. The USG preferred that the money go to extend more care rather than to do better care for those people who were lucky enough to have one of the treatment slots. Another thing happened, which is that in the middle of about year 5 or 6, I all of a sudden realized in a meeting that we would have like every few months with all the site leaders, the site clinical leaders, I realized that there were patients who were on third-line drugs. Now, first-line drugs cost like, $20 a month per person. Second-line drugs cost like $200 a month per person. But third-line drugs can cost like $3,000 per month per person, even in Nigeria. Because the only place you can get these third-line drugs is from pharmacies in the EU and the US and Israel and a few other places. And so I found out that without asking about it, that some of the clinicians had put about 15 or 20 patients onto third-line drugs in Nigeria. Now, they thought they were doing that for appropriate clinically indicated reasons because these patients, according to the viral load testing and the CD4, had failed first and second-line drugs. But they were now using a massive quantity of funds that would be better spent as a public health measure on treating others with first and second-line drugs. So what did we do? So we were already in the pickle, right? Because we already had a commitment to these. We couldn't stop giving the drugs to these 15 patients. So what did we do? I mean, this was like a 3-hour discussion, and then we had to make a decision about it. So we said, and they got mad at me, but I said, no more third-line drugs in Nigeria for our patients. No more. It's too much money, and when the U.S. government finds out about it, they're going to flip. So, and I said, the money needs to be spent on more people on first-line drugs. But I said, for the 15. We can't interrupt their care. So what we actually did is we did a couple of things. We tried to get drug donations. from the pharmaceutical companies to cover that 15 in perpetuity. And we took some of the indirect cost recovery that was generated by the entire PEPFAR grant, which at its height was about $90 million a year to Harvard. So it threw up a lot of indirect cost recovery for Harvard. We took some of that money that was university money and we paid for the third line drugs with it. But this is an ethical issue that doesn't come up with the drug assistance programs in the US and with Medicaid paying even for third line drugs. Then there's the issue of the continuity of care. And the continuity of care is less of an issue in PEPFAR because the money is continuing. It's much more of an issue in clinical trials that are done, either NIH-funded trials or pharma company-funded trials. What does one do with continuity of care, both for the control group and for the experimental group, after the trial is over? There is no good answer for this, but again, it goes back to the issue of the background standard of care is sometimes just, it doesn't support continuity of an acceptable standard of care after the study or the project ends. So what does one do about that? This is something that I have written about with Bernie Lowe and Nancy Padian. And our general feeling is that to give, after a trial ends, and this is controversial, I will admit, but after a trial ends, to single out those people who participated in the trial for better treatment than anybody else in the entire community, itself exaggerates and exacerbates care differentials and disparities in delivery of care. So the money that so we have hypothesized that the money that one spends, that would spend for continuity of care for that select group of patients instead should be spent on community-based interventions to raise the level of care, or at least the training of medical professionals or laboratory services for everybody in the community rather than singling out those individuals. But that's a tough choice, that's a tragic choice, because it leaves those individuals high and dry. And the other thing that one has to think about, this is a very complicated issue. It's much more complicated than it's sometimes made out to be in the public dialogue. But in pharma company-sponsored trials or in NIH-sponsored trials, often these drugs are being tested in phase 2 or phase 3, and even if the drugs are efficacious, they may never be marketed. They may never be approved. So what does continuity of care even mean in that situation? I mean, you can't keep producing the drug for a group of patients in order to continue an experiment when the drug itself is never approved. So this is it's more complicated than just mean pharma companies wanting to deny care after a trial is over. One of the problems that this is less of an ethics problem than it is of a practical problem, but one of the problems is data collection and the accuracy of data collection, the integrity of data. And one of the reasons why there is often this problem, at least that I found in Nigeria and Tanzania, is that the quality of medical record keeping in the public hospitals is very poor. So if the medical record keeping is poor and the nurses and clinicians have been trained to treat and to emphasize treatment rather than recording in a beautiful medical record in the way it's done here in electronic medical records that are easily accessible across the country, if they're not doing that, then how do we expect them to do beautiful case report forms? I mean, it's two different standards in the same clinic between the research patients and the other patients. So we spent a lot of time actually training in medical records keeping and then trying to cross-train staffs outside of the HIV clinics in how to keep better medical records. Another problem that which is a political problem, and I will relate this in my own experience, but traditionally these NIH-funded grants, they're $100,000, or they're $200,000, or they're $300,000, and they require the salary of 2 postdocs, support for a couple of graduate students, and partial salary support for the PI and one other faculty member, and their research. And so in one laboratory, a person who is a scientist, who's never been trained in management techniques or care delivery, can easily implement a $200,000 grant because they're seeing these people every day. They know about time and effort reporting. They know what they're doing. This is not a problem, right? But what about when you take the PI model, where the PI is truly the boss of everything in a grant, and the grant becomes a $50 million a year grant, which has nothing to do with research and everything to do with care delivery 8,000 miles away. And think about, security systems, drug supply chain, medical supply chain, credentialing of doctors and nurses and laboratorians. It's like starting a hospital from scratch, right? So if the PI is not trained to do that, how can the institution trust the PI to be the manager of this money. I mean, the scale is not, the PI model does not fit the scale and the purpose of these grants at this point. And so there is a struggle that goes on between, in the PEPFAR program and in many other places, between, now not in Catholic Relief Services, because Catholic Relief Services, Liz Glazer, are clear. They say our scientific director is the boss, is the PI, and that scientific director does what he or she is told to do. It's a command and control system. Catholic Relief is a command and control system. You do what you're told to do. At Harvard and Hopkins and other places, the PIs don't like to be told what to do. Right? So I'm not telling you anything that has not been published, but when Larry Summers and Steve Hyman called me when I was on the beach in Croatia to tell me that they had bought a year of my time for my law firm, and that I was the first executive director of the PEPFAR program, my first question was, well, first of the question was, do I have anything to say about this? Do I have a choice about this? And the answer to that was no. But my second question was, what about the PI? And so this has been published, so I'm not saying... Larry made the PIs, all three of them, sign a paper which said they reported to me for everything except the science. You can imagine. You can imagine how popular that was, right? But the three PIs had never done anything that remotely approached this in terms of the scale, the complexity, the delivery. None of them had ever been responsible for the delivery of real healthcare services. So this is our model doesn't fit the risk parameters and the way in which these things, these kind of huge projects are being done. There is also the issue of project wind up and wind down, and I will tell you one of the most, one of the saddest things that one can see, and you have to guard it. This is so easy to fall into. Whatever you say when you start a project in a resource-constrained setting, and that could be in Baltimore or it could be in Nigeria, it could be anywhere in a resource-constrained setting. When you start the project, whatever you say that promises things or holds out the promise of things in the grant or in the project will be interpreted in the most optimistic way by the hearer. And so if they think that there's going to be equipment, that there's going to be staff salaries, that there are going to be all these things because you've talked about them, then they are going to be sorely disappointed when you cannot meet all of those expectations. And that's true of the patients as well as of the collaborators. So one of the things that I say to that I would say it to Harvard, at Harvard to everybody, but it was especially to the PEPFAR program, is you better think about how you're getting out before you ever get in. You better think about the expectations that you've created and make sure that you don't do the very cruel thing of over-promising and under-delivering. You should under-promise and over-deliver if you're going to do anything, right? And I've also had other situations in which there were research projects that were aborted for one reason or another, including an HIV vaccine trial that I was involved in one time. That was aborted because of the Merck HIV controversy that occurred in the vaccine results in that study. And when that vaccine study was terminated kind of abruptly, when accrual had just begun and we'd already bought a study house and trained everybody and everything was done, the degree of disappointment of the investigators in Zimbabwe, which was where that study was heartbreaking, you know. And so what do you do in that situation? What I did is I tried to get them some other grants, and I did, in order to do other kinds of research. But that was it's not everybody does that. We'll go to that length to do it, to kind of fill the gap that way. Patients often think, or subjects think, if they see that it's a Hopkins study, they think that Hopkins is their treating doctor. And so you have to make crystal clear in the consent form and in the verbal consent process, like who's really the provider here? And it's not Hopkins. It's somebody else funded by Hopkins. Shakedowns for cash. I won't tell you what I did with all these situations. I never use federal money for anything. There are solutions, but the major solution that I found was to ship everything into the U.S. Embassy and then retrieve it from the embassy. Because all of the customs officials, this is one of the major problems, right? The customs officials will tie things up at the airport and they will leave them on the tarmac with the drugs sweating, right, until you pay an access fee. what is euphemistically called an access fee. And this happened to us, right? And so I quickly wised up after the first shipment of about $30,000 from Western Europe, and ended up I had to throw it out in Nigeria. But the way I did it was I did not pay bribes. It is actually legal, just so you know, under the Foreign Corrupt Practices Act, to pay people to do that which they ought to be doing anyway, like stamping a passport. It's actually legal to give them money to do that. But it's not legal to to give money or any kind of benefit to a government official abroad to do something in which they truly have some kind of enforcement discretion. So you have to pick your way carefully, but the best alternative is to plan ahead and not to get stuck there and not to waste $30,000 in drugs on the tarmac in Lagos. There is also the ethical issue of silence, gag clauses, selective reporting of research results. I have negotiated agreements like MOUs with sovereign governments, not only in Africa but in other places, in which the government says, we want to be able to, as a precondition for doing research here, you must let us look at the publication, the draft publication, and have veto power over it before it is submitted to a journal. Now actually, under good research ethics or institutional ethics, you can't do that as an investigator. But why do the countries ask for this? They ask for this because their experience has been that investigators from XYZ University in Heidelberg or in California or wherever parachute in, do the research, rely on collaborators, go back and publish it in the Lancet without any attribution of credit to anybody in the country. And so this experience has made them bitter. They're also concerned in the ministries of health that there will be findings in epi studies, for example, that reflect negatively. For example, on the efficacy of HIV prevention efforts, or TB prevention efforts, or TB treatment, DOT efforts. And so there are these requirements that they try to impose for essentially gag clauses. They want pre-screening of our research because they don't want what's published to harm, in a reputational way, either the government or the people or the communities. And so that is, you can't agree to that. But the way to not agree to that is not just to say no. The way that I found is to start asking, what is it that you're really after here? And try to accommodate the concerns about appropriate attribution, appropriate co-authorship, etc. And then there is the reverse gag clause, which is that the American institutions try to stop the local collaborators from talking to the media. Because the media, the Western media is merciless, right? And so they will send reporters into the most remote areas of Nigeria, in Maiduguri, in northern Nigeria, which most people can't even go to anymore, because it's the home place of Boko Haram. They will send reporters to kind of try to talk to the local investigators and get dirt on an American-funded, NIH-funded, or EU-funded project. And so the response that I have seen some investigators kind of fall into is to say, to the local collaborators, don't say anything. You must not say anything to anybody, which is also not the solution. But it is wise to educate local collaborators about the ethics of Western journalism. Then just a couple more slides, and then I'm going to break for questions. One of the great disparities that emerges in these projects, whether it's service or research, is that the American staff, the expatriate staff, is paid at like 10 times the rate of the local staff, and they work alongside one another. Is that equal pay for equal work? It's not. And so how does one rationalize these things, right? It breeds, everybody knows what everybody makes. You just forget about confidentiality. And so you have these American kids who are like 24 years old, and they're sitting in the desk next to a doctor who's labored for 30 years in his or her country. They're making the same amount of money, doing very similar tasks or the same task. And the American kid is going out like to dinner every night. And the doctor has a decent salary from the NIH-funded project. But he or she is supporting like a family of 10. They can't use the money, and they're getting paid only a tenth of what the American kid is getting paid. So, where's the fairness in that? Resentment is everywhere. One of the ways that I solve this as to prevent the worst excesses is to counsel the kids or the naive American, expatriate, EU, other people who are there, cut their salary way back, and give them a bonus payment after they finish the year in country. so that they don't have that excess money for that year. But those are the only ways that I found out how to do it. Project finances. Who gets any of the excess money that comes out of funding of these projects? You know, this is the this debate goes on at Hopkins like it goes on every other medical center complex in the U.S. But if the money comes in, does it go to the clinic? Does it go to the department or the service, or does it go to the institution? Right. This is the debate. Right. Or does it go to salaries or not? So what you definitely want to avoid is paying a huge institutional tax at the very top, and the people who are actually doing the work in the clinics or doing the work on the research actually get pennies when there are substantial kind of per diems or honorariums that are taken by the top executives. And so you have to play tough in order to resolve that ethical dilemma of equal pay, of the right pay for the right work. So, but it's a lot of bruised feelings that can result from that. Quality assurance. Any good clinic system has to make sure, has to evaluate the quality of the services. The first meeting that we had in PEPFAR with the federal government officials, I raised my hand and I said to Mark Dybel, what are we doing about quality assurance? The answer in that big room with those first four grantees was, we're not worried about that, we just want to get it up and running. Don't worry about that. So from the beginning, there was no quality assurance in PEPFAR. We eventually put it in, but trying to build in quality assurance in a culture which is not a medical culture that's not accustomed to it, is viewed as trying to single people out for blame. And so trying to work through that, both on the audit side for the financial and administrative people, getting accustomed to Price Waterhouse doing audits and having findings and having corrective action plans, and on the clinical side, having adverse event reports and findings and chart surveys, and trying to get people not happy, but at least not antagonistic to the idea that the reason to do this is not to fire them, it's to try to help them be trained to do a better job and to improve the SOPs. A huge cultural gap there with some significant. And then this is the final thing the final example, which is this is a true story. So actually, when I wrote this slide, I wrote it because I thought it might be given out, so I didn't want the names, but I'll tell you what it is. So trying to, if you have a clinic system with 200,000 patients, you've got a supply chain coming in from India, from Western Europe, from the US, in some cases from South America, and you've got to modulate the supply chain, because if you order too many drugs, they'll expire. You'll have to burn them, right? If you order too few drugs, you'll have stockouts. That will erode the confidence of the patients and the providers in your system. We ran a huge pharmacy operation. We built a warehouse in Lagos to handle all these huge shipments that came through the US Embassy to avoid all the shakedowns for cash. And so when we did this, we made some mistakes. And there were some drugs that were, so at one point, there were drugs that were about to expire. Huge quantities of drugs. It was selected. We had plenty of AZT and not enough of this. Not enough of efavirenz, but plenty of AZT. So in 6 months, these drugs were about to expire. And so the people in Nigeria said to me, what are we going to do, put them in the incinerator? We don't want to give them out to the clinics even in Nigeria, because we don't want the clinic in Maiduguri, which is only getting shipments intermittently, to be giving out in 6 months these drugs after they've expired. So what are we going to do? And I said, my God, I mean, this is like $3 million. I think it was $2 or $3 million in drugs that had actually been ordered in one of those interim periods when I was not the executive director of PEPFAR. And but we had to deal with this problem. And so I looked around, and it turned out that the health minister of Zimbabwe was a friend of mine, David Perinyatwa. Now, Zimbabwe was off the list of the PEPFAR countries because of the geopolitical concerns. So I knew that there were essentially no antiretrovirals in Zimbabwe except for the wealthy who could, people who were members of the ZANU-PF who could go and buy them in Johannesburg and bring them back. So I thought, look, this is not like a full pharmacopoeia of these drugs. It's not everything you need, but it's at least it's a lot of AZT, it's a lot of some other things. So what about we give it to Zimbabwe? So I approached HRSA and the in-country CDC, and I said, can we ship these drugs? I said, David Perinyatwa says to me that he can use these drugs before they expire in Zimbabwe. Can I take these drugs in Nigeria and ship them to Zimbabwe? And so, of course, trying to humor me, these people said, oh yes, you can do that, but it's got so many permits you have to get to go through this and get this. So they thought that there was no way that I would pursue this. So within 2 weeks, I had the export permit from Nigeria, the import permit from David Perenyawa in Zimbabwe, and I had British Airways willing to carry it for free, from Lagos to Harare. And so then I called them back, I called HRSA and I called CDC in country in Nigeria, and I said, we're ready to make the shipment. All hell broke loose. The US government cannot be sending about to expire drugs to Zimbabwe, even though we all know that, first of all, David Perenyawa was willing on behalf of Zimbabwe to sign a paper saying, I understand when these drugs are expiring and I'm the health minister and I'll take them anyway. And even though we also know that drug expiry dates are really not really the expiry dates in almost all cases. They're good for another year after those expiry dates, right? But the US government didn't want to be tainted with it, and they thought that now Mugabe is only going to blame us for dumping drugs, right? So all hell broke loose. So they forbade me to send those drugs to Zimbabwe. Those drugs were burned in Lagos. However, the press got involved. This was the South African press and the Zimbabwe press about the US government burning. I mean, it was the opposite, which is what I told them. The US is burning drugs in Nigeria that can go to Zimbabwe. So the US was embarrassed into having to actually pledge 3,000 treatment slots of drugs to Zimbabwe in perpetuity. So drugs that got burned ended up through this, sort of Machiavellian way of working this. It ended up with 3,000 treatment slots being opened in Zimbabwe. So anyway, I'm going to stop there because I'm over time and I know you want time for questions. So.
We have time for a few questions. And Mark, you'll call on them. Surely there's a question.
Or comments.
Yeah.
Yes, sir.
How come you didn't get fired?
I don't know exactly, but I'll tell you, the truth is that I have done, I mean, whether it was like running the Ryan White Care Act, program in New York, or whether it was, being an AIDS lobbyist in Washington, which is another thing that I did for a couple of years when the Republicans took over Congress in November of '94. I mean, I have done these things that have been like, sort of enormously controversial, right? And my attitude has always been, fire me if you want to. That's been and I'll tell you, having that attitude, takes away the threat. But I have to say, I mean, the reason I'm lucky. The reason I've been able to do that largely is I've got a partner who's a doctor who's goes to the clinic every day. We're going to have a salad. We're not going to starve. And I've said to him in many cases, I'm like, thank God you're there, because that enabled me to do, to basically tell everybody else to go, you know what, But if you do what, sometimes when you do these things, you get your teeth kicked in. But I've never been fired. I've been yelled at a lot, but I've never been fired. Yes, ma'am.
Could you talk a little bit about the sustainability considerations that you made in creating locally registered NGOs versus passing the NIH for transition?
Yeah, one of the issues in the PEPFAR transition, and because actually what we did at Harvard has is now written into the Ryan White the PEPFAR reauthorization, that every PEPFAR grantee in the U.S. now has to have some kind of a plan of transition but it could be a transition to the Ministry of Health or the local health departments or local health offices, or it could be to an NGO, or it could be to a faith-based organization, whatever. The Catholic Relief Services has the advantage here because there are Catholic missions everywhere, right? So they have local infrastructure that's beautiful.
Yeah, I'm coming from April.
You're what?
I'm coming from April.
Oh, okay. So you know this then, right?
Yeah, I'm just curious about.
Yeah. So we talked about whether instead of whether we should help the Ministry of Health in each of these three countries, actually do this instead of building a new NGO. In Botswana, that's actually kind of half of what we did. But that's because the Ministry of Health in Botswana works so well. But when we evaluated Tanzania and we evaluated Nigeria, I mean, even though the people in those ministries with whom we worked were fabulous, ethical people, the the systems, the economic systems are so bollocks that we thought that if we really did that, it might look good on paper, but it would fail as soon as we left the country. And so the only thing that we knew to do, then we looked around. I scouted in Tanzania and in Nigeria trying to find an existing local NGO. I didn't find one. And we even did like an RFP in Nigeria, and we got like some real fly-by-night places that we had nevertheless evaluated. So we went through this process of trying to decide, and that was the best we came up with. So, but these are big organizations. The one in Nigeria has like 150 employees, and the one in Tanzania has about 100 employees. So.
Probably one more question.
Okay.
And we don't? I am shocked. There's Chris. Yeah.
So one of the challenges I think we're facing right now is the new WHO guidelines going up, starting at 500 CD4s.
Right.
And, I think there's a broad consensus that that's the right thing to do, but a challenge is countries that are using old drugs. And where, the benefits of early therapy with drugs that, cause things like peripheral neuropathy are really a challenge. And so I wonder just, if you could reflect on that and if that is at all an issue in thinking around the 7-1. I know South Africa has phased out some of the OP14. Zambia, I don't know.
Yeah, I didn't get to talk about Oso Point, which is itself a very interesting study. It's a 3-arm study that's being done in Zambia and South Africa, and there are 3 arms, but one of the arms, the most invasive kind of experimental arm, is actually home-based, like aggressive home-based offering of home-based testing in large communities, and enrolling every single person, or offering enrollment to every single person who tests positive into antiretroviral treatment. And so one of the ethical issues about even doing a study like that is why are you studying something that really can't be, that at least today can't be done? I mean, you're erecting you're testing a standard which is not achievable in a resource-constrained environment. I mean, the answer to that is sort of like there is no good answer to that, right? I mean, it's an issue. But I mean, one of the answers to that is the same kind of answer that I would often give to people who are critics of drug companies or NIH-funded universities or academic medical centers testing drugs in a developing world context or an emerging economy, in which it is probably the case that if this drug is ultimately approved, it's going to be too expensive for most people in the country. And I'll tell you what I've said about that is, yes, that's probably true. But if the drug does get approved, there will then be at least an opportunity for price pressure and political pressure, and the market will work itself, and so the price will come down. So why not test? Because the fact that we did test has now allowed there to be like $20 a month supply of antiretrovirals from Ranbaxy. So, I mean, I think to that particular question, I think that's as good an answer as you're going to get, which is, why settle for second best? Why not look, try to set the standard for what's best, and then we can come in behind it through advocacy and, and try to use that as the standard. I don't know any other way to say it.